From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA podcast on the subject of sickle cell disease. I am Mary McDermott, a deputy editor at JAMA. Today, I'll be speaking with Dr. Patricia Kavanaugh, and we'll be talking about her new review on sickle cell disease, which will appear in the July 5th issue of JAMA. Welcome, Dr. Kavanaugh, and thank you for joining me today.
Thank you so much for having me.
And could we start by having you introduce yourself, please?
Yes, my name is Patricia Kavanaugh. I go by Trish. I am an associate professor of pediatrics at Boston University School of Medicine and Boston Medical Center. And I've been working in the area of sickle cell disease since 2006, clinically as a pediatric emergency department physician, but also doing research trying to improve the care and outcomes for sickle cell.
Thank you for joining us today, Dr. Kavanaugh. First, could you start by defining sickle cell disease?
Yes. So sickle cell disease is an inherited disorder of hemoglobin. So it's one single base pair alteration in the DNA that codes for hemoglobin, which produces hemoglobin S. Sickle cell disease is seen when it's inherited in an autosomal recessive manner and occurs when a hemoglobin S combines with a second hemoglobin S gene or another hemoglobin variant, such as hemoglobin C or beta thalassemia. Our understanding of what happens in the pathophysiology of sickle cell disease has evolved significantly over the last 2 decades. We now understand that the pathology seen in sickle cell disease stems from 2 key pathways. First, when the sickle hemoglobin becomes deoxygenated in the capillary beds, it forms these long chains or polymers within the red blood cell, and it causes the red blood cell to assume the sickled shape that we all think of. These sickled red blood cells differ from normal red blood cells because they have increased adhesion molecules, which allow them to stick to the inner surface of capillaries. And they also then interact with white blood cells and platelets. And it's this process which leads to vasoocclusion. But in addition, so this is what I learned when I was in medical school, but in addition, sickled red blood cells are brittle. They last about 10 to 14 days compared with hemoglobin A or adult hemoglobin, which is the most common type. Adult hemoglobin lasts 120 days. So these sickle red blood cells hemolyze or break open very frequently, and they're releasing free heme, which is depleting nitric oxide and leads to endothelial dysfunction and vasoconstriction. And it's the combination of vasoocclusion as well as the endothelial dysfunction which activates an inflammatory response and perpetuates vasoocclusion, which then leads to all the complications that we see with sickle cell disease.
And how common is sickle cell disease worldwide and in the United States?
So worldwide, it's estimated that 300,000 infants are born with sickle cell disease each year. These are infants born with the most severe form, hemoglobin SS disease. More than half of these children are born in Nigeria, India, and the Democratic Republic of Congo. It's also common in the Mediterranean region and the Middle East, but is now present in most countries just due to migration, as well as the transatlantic slave trade. In the U.S., approximately 100,000 individuals live with sickle cell disease. These numbers, you may be hearing me say approximations, because we don't have a national registry either in the United States or elsewhere in the world.
What is the life expectancy of people with sickle cell disease living in the United States?
So individuals living with sickle cell disease in the U.S. have an average lifespan of 54 years, which is approximately 20 years less than the general population without sickle cell. This is largely caused by the damage that's occurring every second of every day to multiple organs, including the lungs and kidneys.
And can you talk about some of the manifestations related to the damage that you just referred to?
Yeah, so the hallmark of sickle cell disease is an acute pain crisis or painful episode. This is characterized by severe, unrelenting bone pain. It is unpredictable and can happen at any time. We see it in children, usually 6 months and older, and it is incredible. Some people can have multiple painful episodes in a year, 6, 8, 10, where others may go for a few years without it. Other complications due to sickle cell disease include acute chest syndrome, which is the leading cause of death. And so what happens is that there is sickling, vaso-occlusion, endothelial dysfunction within your lungs. So there is the oxygenation mechanism of your lungs is disrupted. Stroke is also very common and seen across the lifespan. So many are surprised when they think about children as young as age 2 having strokes. But this is unfortunately a common occurrence in sickle cell disease, especially ischemic stroke. Hemorrhagic strokes are also seen in early adulthood. And finally, sepsis is something we always worry about. It was a major cause of mortality in children in the United States prior to the introduction of penicillin prophylaxis, and is still a leading cause of death in other areas of the world where sickle cell disease is not diagnosed until a complication arises.
I'd like to talk about treatment, and I wondered if we could start with the traditional treatments for sickle cell disease.
So one of the most important treatments for sickle cell disease is hydroxyurea, which has been used to treat sickle cell disease for more than 25 years. It was initially studied in adults with the most severe genotypes. That would be hemoglobin SS disease and S beta 0 thalassemia, who had frequent complications, including 3 or more pain crises a year or recurrent acute chest syndrome. It was shown to be very effective for these complications. And over time, they continued to follow that original cohort and was shown to have a significant mortality benefit as well. So now hydroxyurea is used as a first-line therapy in adults. For children, the first landmark study was published in 2011, and they studied hydroxyurea in those with hemoglobin SS and S beta 0 thalassemia, the most severe genotypes, in babies starting at 9 months of age. And they have found that hydroxyurea is safe and has also reduced complications associated with sickle cell disease, including pain and acute chest syndrome. So now hydroxyurea is used as first-line treatment for those with the most severe genotypes, as well as those with other genotypes such as hemoglobin SC disease, S beta plus thalassemia, especially once they have complications related to their underlying sickle cell.
Your review discusses that 3 new treatments have been approved since 2017 for sickle cell disease, and I wonder if you can talk a little bit about those treatments and who they're indicated for and how effective they are.
Yes, so it's been an exciting time in sickle cell disease. So since 2017, there have been 3 additional therapies approved for sickle cell: L-glutamine, crizanlizumab, and voxelotor. So the first, L-glutamine, is an amino acid supplement, which can decrease reactive oxygen species in red blood cells. And that means it can decrease sickling and the adhesion that we see with the sickle red blood cells. It's been shown to reduce acute pain crises by 25% and hospitalization by 33%. So this is recommended as an adjunct for those with severe sickle cell disease when they're having multiple complications. Crizanlizumab is a monoclonal antibody that's directed at P-selectin, which is an adhesion molecule on activated platelets and endothelial cells, so inside those capillary beds, which can mediate vaso-occlusion. This is an infusion, so you first do a loading infusions every 2 weeks, and then it's a monthly infusion. And when it's been shown to decrease pain crises from approximately 3 times a year to about 1.5 per year, which is a big improvement for those living with this awful condition. And finally, voxelotor is the latest addition to the armamentarium. It stabilizes hemoglobin by promoting the binding of oxygen to hemoglobin S, thereby decreasing the polymerization, the formation of those long rods, and the hemolysis that results. So voxelotor is still early in the understanding of its benefits. So far, we've seen that it significantly increases hemoglobin in individuals. So this trial was looking to see how many people had hemoglobin raised by 1 gram per deciliter. And they found that with voxelotor, 51% had this increase of 1 gram per deciliter compared to 7% of those who were randomized to placebo.
Great. And how about stem cell transplant? When is that indicated?
In the US, stem cell transplant is typically indicated in patients with severe disease, such as individuals who've had frequent pain crises, recurrent acute chest syndrome, or previous stroke. Those who do best are children with sickle cell disease who have a matched sibling donor, as they have not experienced as many complications related to sickle cell as adults have. However, not everyone in the United States or worldwide has a sibling donor. Notably, there are several active research protocols for adults living with sickle cell disease who have unrelated donors, and many investigators are working hard to improve outcomes in this population.
I wonder if you can talk about some of the social, cultural, and structural challenges that patients with sickle cell disease have faced.
Yes, individuals living with sickle cell disease face significant challenges. On an individual level, day to day, they're trying to manage their disease as well as the mental stress caused by living with a life limiting, unpredictable illness. This leads to strains on their social fabric of life, including their educational attainment, their ability to work and hold down a full-time job while managing their disease, and relationships. In addition, patients with sickle cell disease, when they seek health care, are often experiencing disease stigma related to sickle cell disease. They are working with clinicians who may not know that guidelines exist for the management of their complications. And this leads to bidirectional mistrust between patients and clinicians, which further perpetuates the complications of sickle cell disease as they're not getting all the care that they need. And then finally, in the United States particularly, there's structural systemic injustices and racism experienced by the Black population have perpetuated the disparate outcomes that are seen for those living with sickle cell disease compared to other genetic diseases such as cystic fibrosis. For the latter, cystic fibrosis, there's a lot of research, there's a lot of funding. In fact, 10 times more funding has been done for cystic fibrosis with enormous gains in outcomes, including survival, when you compare dollar for dollar spent on sickle cell disease.
Can you comment on how these challenges might be overcome?
Certainly. The most important really is education of all clinicians who interact with patients with sickle cell disease, from the bedside nurse to clinicians across the care spectrum, from outpatient clinic to the emergency department to the inpatient setting, as well as those who are trying to support them, social workers, just to understand just how devastating this disease is. Another way to overcome these challenges are we need data. I've talked so many times during this podcast giving approximate numbers of individuals living with this disease. Even in the United States, given our wealth and our privilege, we really need to set up some registries to really track the incidence of complications, see how people are doing these days. We have some cohort studies, but the lack of data in large populations really limits our ability to care for these patients optimally. And finally, we really need to increase the number of clinicians who are educated and are caring for individuals with sickle cell disease in the outpatient setting, both hematologists as well as primary care clinicians. Some studies have shown that when patients are co-managed by specialists in primary care, they do far better than when they're managed by one alone. And so I think these three answers will definitely help contribute to solving some of the issues that patients with sickle cell disease face.
Thank you, Dr. Kavanaugh, for this really informative and thoughtful discussion of your review article in JAMA. Are there any other comments that you would like to make?
I think the last comment I would make is that there's a huge crisis going on in the United States with respect to the opioid epidemic. Patients with sickle cell disease often are experiencing both severe acute pain crises as well as chronic pain, and face enormous barriers to being managed appropriately, which often include opioid therapy. These patients really have a severe underlying disease and should be taken out of the restrictions that other individuals face with respect to opioid prescribing. When we look at the prescriptions filled by patients with sickle cell disease as well as opioid deaths, we have not seen any change over the last 15 years in the sickle cell population, whereas we've seen enormous changes in the general population in the United States.
Thank you so much for all of the helpful information. I've been speaking today with Dr. Patricia Kavanaugh about her review in JAMA on sickle cell disease. This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Jesse McQuarters, Shelley Stephens, Lisa Hardin, Audrey Foreman, and Mary Lynn Ferkulak. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. There is a link to the article we discussed today in the show notes. Thank you so much for listening.